Welcome to the U.S. Healthcare System Lecture Series by Monika Wahi, based on Essentials of the U.S. Healthcare System by Shi and Singh.
Welcome back. I hope you enjoyed the first lecture over the first half of Chapter 1. This is the second lecture on Chapter 1, and we'll cover the second half. In the first half, we covered the different subsystems of the U.S. healthcare delivery system and how these are integrated or not integrated into integrated delivery systems. Now, in this lecture, we will compare that complicated system to that of other developed countries and maybe see why we need all these subsystems in this integrated delivery system because we don't have what they have.
Chapter 1, Major Characteristics of the U.S. Healthcare System, second half. Learning objectives. At the end of this lecture, students should be able to name 3 characteristics of the U.S. healthcare delivery system, name at least one way in which the U.S. healthcare delivery system is different from that of most other developed countries, such as Britain, Canada, and Japan, and explain what a systems framework is. Characteristics of the U.S. healthcare system. The textbook focuses on 10 main characteristics of the U.S. healthcare system. These characteristics make the U.S. healthcare system especially unique when compared to other healthcare systems of developed countries. We will go more in depth into each of these categories. The first one is that there is no central governing agency and little integration and coordination. You will see the implications of this in future lectures. Next, in the U.S., the healthcare system is technology driven. It provides a lot of curative care, but not so much preventive care. This can lead to the fact that it is high in cost. Also, with the way we set up insurance, it is unequal in access. Unfortunately, at the end of the day, our healthcare system is average in outcome compared to other developed countries. The delivery of healthcare under imperfect market conditions is another hallmark of the U.S. healthcare system. That is how market justice comes into play. The government is a subsidiary to the private sector in the U.S. healthcare system, whereas in other healthcare systems, the government runs it. In addition, in the U.S. healthcare system, there is a fusion of market justice and social justice, as mentioned before. The social justice that is necessary to deliver healthcare goods to everybody is mitigated by the market justice, which tries to help it find the right cost and improve utilization. There are multiple players and an unusual balance of power in the U.S. healthcare system. Without the government as a central agency, everybody is fighting for a seat at the table. And this leads to a quest for integration and accountability. With all these players and all these systems, it is difficult to integrate and it is difficult to hold people and systems accountable for people's health. Access to healthcare services is not universal in the United States. It is selectively based on insurance coverage. Of course, we are all working on this, but it still remains the case that a person has to have some sort of insurance coverage in order to access regular healthcare services on a regular basis. Finally, because the U.S. healthcare system has so much market justice involved with the social justice, and the government is not the main player, legal risk influence practice behaviors. The first hallmark of the U.S. healthcare system that we will go over is the fact that there is no central governing agency. In other countries, this is normally the government. However, it could be a private agency, but there just isn't one here in the U.S. So therefore, there is little integration and coordination. I often give the example of Walmart. Imagine Walmart had all these different stores, but no headquarters. What if the Walmart in Brainerd, Minnesota wanted to sell completely different things and act completely differently from the Walmarts in Miami? This would create little integration in the Walmart and they probably wouldn't make very much money. Central systems are less complex and less costly, and usually centrally controlled things work better, and that's the way it is normally in the developed countries. Not being centralized adds a lot of complexity. First, a lot of payment has to transfer hands, and that's usually done by way of insurance, and then the insurance has to deal with delivery mechanisms. Even diversity within the government causes a lot of chaos. When you have Medicaid and you have Medicare, it can be very complicated. If you are trying to get on Medicaid, it can be complicated. If you are on Medicaid and trying to access services, it can be complicated. Healthcare is financed both publicly and privately, and so therefore this interaction between public and private financiers also adds a little bit to the mess. Private insurance through employers or individually purchased insurance acts similarly to governmental programs, but of course they're different, and sometimes people have both. We are unique in our U.S. healthcare system in that we are particularly technology-driven and focused on acute care. The U.S. invests tons and tons of money in research and innovations and loves to create new medical technology. This growth in science and technology helps create fancy, high-tech, expensive things, like robotic arms for surgery, and great new drugs. In fact, we in the U.S., us patients who are lucky enough to have access to care, we demand all that fancy stuff. And now there are shrinking resources for that fancy stuff. And in fact, they're shrinking resources for all kinds of care. Because we spend so much on robotic arms and fancy drugs and fancy devices, we don't have enough money to cover our entire population. So a lot of people go without basic preventive care and basic vaccinations and other things. So technology has been implemented with some success, but it is obviously overused. And the cost of botched technology is not trivial. However, it's mostly indirect. The people who pay for the cost of botched technology usually don't even know that the technology was out there, because those are the people who are simply not getting care because there's not enough money to go around. This botched technology implementation affects employers and employees because they have to pay for it in their health plans. Technology in and of itself is neither good nor bad. Only implementation makes it so. Imagine an electronic medical record system that is perfectly good. However, it can be implemented badly and completely screw up the clinic. In other words, break things that are already working. However, that same EMR system could be implemented properly, probably in the same clinic, and actually make things easier, make the clinic run better, make things more cost effective, and get the right kind of care to the right people in a better way. The same technology. An older article in 2003 by Dr. Paul Smith talked about his EMR experience and gave to everybody some keys to success. If you review these keys to success, they will look familiar. They look like generic keys to success in leadership. First of all, with the EMR implementation, you need clear definition of goals, just like with any technology implementation, because technology can be used for a lot of different reasons. What are you trying to do with it in your healthcare subsystem? The implementation needs strong project leadership team, and that team needs to run and lead the implementation. How many times have we worked with a coworker who brought to work something cool that they made at home and then tried to implement it? There's no project team. There's just people who are working on the side trying to get this to work. That doesn't work very well. You need a project manager with sufficient dedicated time. You need to hire people, and you need to dedicate their time to this project. The project needs a strong physician leader who will champion the project, so people can look up to this person and go to this person as the contact person. And even when people are faced with things they don't want to do, which is like test new software or go to trainings, this person can champion that and help them. One of the things that's really missing from a lot of our technology implementations in healthcare is a detailed analysis of workflow and a high level of staff flexibility. That sounds like fancy talk, but all it really means is going in and seeing what actual people are actually doing in the healthcare system. Figuring out what are the nurses doing, what are the patients doing, who is receiving them, what's going on with administration, how does billing work, and having a high level of staff flexibility. One of the things that people encounter when they try to implement technology in healthcare is that some of your most important, talented people are the ones that have little or no training. I cannot repeat how often it is the case that an EMR has an epic fail because they simply did not listen to the people who don't have any degrees. Those tend to be the people who interact the most with the EMR. They know the most about the healthcare system, and they can give you the best advice. High level of staff flexibility is important. These people need to be promoted, whether it's with money or nice praise or leadership positions, because these people will tell you how to implement your EMR. They will tell you what their workflow looks like. They are the place where you can really save them money and really make them happy. They don't want to double data enter everything, okay? And you don't want them to be doing that either. At the end of the day, a good leader will pull the team together and the organization together and make a commitment to plan for the worst and hope for the best. And that's the best you can do with any technology implementation in the U.S. healthcare system. High in cost, unequal in access, and average in outcome. Sounds like a VIP room at a nightclub, but instead it's the U.S. healthcare system. It is very high in cost. The United States spends more than any other developed country on healthcare, and the costs are rising at an alarming rate, so we have to care about this. You would think that if we're spending so much money on healthcare that everybody would have it. Yet, other countries spend less than the United States on healthcare and everyone has it. How does that happen? Access is the ability to obtain healthcare services when needed. It is very unequal in the U.S. When people need healthcare services, not all of them have access. Financing and insurance are the key predictors of access. And since many U.S. citizens have limited access to basic care, they are not even going and they are not even contributing any money to the system. So why does it cost so much? Why is it unequal in access? And at the end of the day, after it costing so much and having not everyone use it, why is it so disappointing in outcome? Access to care in the United States is a big topic because it's not a topic in any other country. So we really can't look at that as a topic. We have to research this access to care problem we have all by ourselves. Access to care in the U.S. is limited to those who have health insurance under an employer. So in order to do that, you have to be able to work. It is also limited to those who are covered under a government program. So you could join the Army or the Navy and get TRICARE, or you could become destitute and try to get on Medicaid. Access to care is also afforded to those who can pay out of pocket for insurance. Now, insurance itself is pretty darn expensive. I live in Massachusetts, where we have a state insurance exchange as of today, and that makes it a little less expensive. However, if I did not live in Massachusetts, I probably would not be able to afford insurance. Those who can afford to pay out of pocket for care have dwindled. They are now probably the 1%ers. If you have ever seen a bill for how much it actually costs to do a surgery, you would see that probably nobody in the U.S., or very few people anyway, could even afford to pay out of pocket. For example, at the bottom of the slide, you will see a hysterectomy. A hysterectomy vaginal cost average in Boston, where I live, is about $20,000. Can you think of even rich people you know who could just fork over $20,000 to get a hysterectomy? In the United States, access to care is determined by 4 factors: enablement barriers, the ability to pay, the availability of services, and payment. Enablement barriers are barriers to being able to access care. Lack of transportation is a great example. If the care is available, but it is too far away and a person doesn't have access, they can't get it. There are other kinds of enablement barriers: racial, cultural, and language barriers. It is very frustrating to see a patient who needs care at a healthcare facility where none of the providers can give this patient care because nobody speaks the same language as the patient. Access is also determined by ability to pay. As we saw on the last slide, almost nobody can simply pay out of pocket for care, so people have to find a way to pay for health insurance. If you don't have a way to pay for health insurance, then you don't have access to care. Also, as you learned in earlier slides, some people who do have health insurance have co-pays and other payments to make that they can't afford, so they effectively also don't have access to care. The availability of services is important. In the 1990s, it became clear that children's mental health was important. However, there was a lack of services. It did not even matter that I was living in Minneapolis. There were few programs that we could refer kids to. I'm happy to say that that has been solved now, but other things that have not been solved are still on the table. Certain rural and remote areas lack adequate services, especially for mental health. Rural areas pose a lot of challenges for specialized services, such as specialized surgical services. Finally, payment. Many providers do not accept patients covered under Medicaid because of low reimbursement limits set by Medicaid. That's just one example of how payment can get in the way even if a person has health insurance. As I was saying, if you have health insurance but you cannot afford your copay, you still have a access problem and you cannot get to your care. And so if you have an insurance that no one takes, none of your providers will accept you as a patient, and then you also will have a barrier to access to care. So as you can see, these four factors are intertwined and they all collude together to try and keep you away from getting care in the U.S. healthcare system. In the United States, it is true that citizens who do not have access to health care through an MCO health plan can try to piece together access. As a composite sketch, imagine a veteran who is a veteran now but was an active duty service member in our recent wars. If that person got a head injury during that time, that person might now, as a veteran, be using public health, military, and vulnerable population subsystems to get treatment, not only for the head injury, but for the post-traumatic stress disorder that can come with it, because it's really scary to have a head injury. And also, a lot of times people who have head injuries then also have substance abuse disorder. So they end up having a lot of healthcare needs. And those coincidentally tend to be the people who are missed in these whole MCO health plans and often end up going to safety net providers. Also, you can think of a composite sketch of a young woman who becomes pregnant at a time when she really wasn't planning on it. Maybe she herself was struggling with substance abuse disorder or simply was just poor and young and didn't have any money. She might go to public health, vulnerable population subsystems, or even the long-term care subsystem to help her through her first pregnancy and her birth. But these are the kinds of people who are looking around and trying to piece together access from our different subsystems. I hope you see from those illustrations that the absence of insurance inhibits a patient's ability to really get health care. In order to go through a pregnancy and a birth, or in order to take care of a long-term head injury, a person needs to receive well-directed, coordinated, and continuous care. They need to be able to access all the primary and specialty services they need. I always think it is funny how we set up these referral services, especially for mental health. We sit down with these lists of providers and tell people where to go. However, many of us ourselves, looking at that list, can simply not afford to go there ourselves. So it is kind of hypocritical that we keep referring people to places they can't afford. The fourth unique characteristic of the U.S. healthcare system is that healthcare is delivered under imperfect market conditions. Under national healthcare problems, like in other countries, the true free market forces are virtually non-existent. patients have varying degrees of choice in selecting providers, but there is not a lot of market pressure on different services or different providers. That's pretty much run by the government. It's kind of like our tap water. It matters where you live. If you want good tap water, you have to move to where the tap water's better. That's because the government runs it. There's really no market pressure. There's really no choice. In the U.S., healthcare is only partially governed by free market forces. So these forces can come in. They can do things. They can make it so that there's competition. And they can do a lot of other things. Since we have brought up the subject of market pressure in the U.S. healthcare system, which is non-existent in other systems, let's just talk a little bit about what a truly free healthcare market would be like, which we don't actually have in the U.S., but what would the traits be? Providers would be vendors and patients would be consumers in a totally free healthcare market. There would be unrestrained competition between the providers on the basis of price and quality, just like car dealerships or other things we selectively buy on the market in the U.S. And patients would be able to choose their provider based on price and quality. So if you don't mind having kind of a junky car because you don't want to pay a lot for a car, you can make that choice. And so patients can make those kind of choices. Or they could say, I want to pay a lot and get Cadillac healthcare. And then multiple patients or buyers and providers with sellers would act independently. So you'd go shopping the way you'd go shopping in a mall. As patients, as consumers, patients would have to have the information about the availability of the various services. There would need to be advertising and easily accessible information about where to go for a mammogram or whatever. And patients would have to make decisions about the purchase of the healthcare services. Nobody else would decide for them. And then the patients would directly bear the cost of the services they received. So if they don't pay a lot for dental care and they get cavities, well, that's the deal. A fifth trait that is unique to the U.S. healthcare system is that the government acts as a subsidiary to the private sector. See, in most developed countries, the government plays a central role in the provision of healthcare itself, kind of like the VA system does here in the United States. But in the U.S., the private sector plays a dominant role because of American tradition and the desire to limit government. So let's think about that. How is the American tradition different from that of Canada or Europe? If you think about our Constitution, that was made up of a bunch of revolutionaries who had come from Europe. They didn't necessarily want to do things exactly the way Europe did. So why have Americans always had the desire to limit government? Well, we want to be individualistic, don't we? And so I believe we wanted to see some economic forces at play in our healthcare system. We thought it might be a good idea. Which brings us to the sixth trait, which is the market justice versus social justice. Market justice and social justice are brought about to talk about in the U.S. healthcare system to try and understand better these balances. Market justice places the responsibility for the fair distribution of healthcare on the market forces in the free economy. As we all know, healthcare is a limited resource. There has to be some way to distribute it. In market justice, we use market pressure to decide that. But social justice emphasizes the well-being of the community over that of the individual. In social justice, the community decides, instead of the market, how to ration out healthcare. Thus, if you're more of the market justice ilk, you would see that interfering with market forces in a free economy would be considered unjust, because then it would feel like you weren't justly distributing your health care. Some people would be getting in unfairly, and some people would be going unfairly without. In social justice, the inability to obtain medical services because of a lack of financial resources would be considered unjust. In other words, having market pressure operate on whether or not a person could get to health care would be seen as unjust. So we have to ask ourselves the question, if we're looking at situations in the U.S., what leans towards market and what leans towards social justice, given that we have a combined system? The nationalized healthcare in other countries occasionally will have supplemental insurance involved that may be offered on a private market, but it's largely a social justice based system. When you have a mixture like this, it becomes difficult to sort of understand how things play out because the two different systems are trying to distribute healthcare in a fair way, and if you mix them together, do you think it's still going to be fair at the end? The next unique trait of the U.S. healthcare system has to do with the multiple players at the table and the unusual balance of power. Normally, in a nationalized healthcare system in other developed countries, you don't have all these people at the table. It's mainly the government. And there's not a lot of balance of power. The government's pretty much in charge of what happens. Who has the power in this system? So far, the key players have been physicians, like through the AMA, administrators of healthcare institutions, insurance companies, which have a lot of money, large employers, which also have a lot of money, and the government. We have to ask ourselves, how do these groups wield their power? And is this fair for patients, the consumers? It reminds me of all of those Greek and Roman mythology stories, where the gods are all warring, while all the people on earth have to suffer. So without central guidance of the government and with all these multiple players involved, there's this constant quest for integration and accountability. Now, the envisioned role for primary care would include integrating all the health care by offering comprehensive and coordinated and continuous services, trying to air traffic control our patients through this complicated IDS-laden system. This emphasizes the importance of the patient-provider relationship, especially with primary care providers, and how it can best function to improve the health of each individual and strengthen the population. How can we best do this air traffic controlling of patients through the system? Integration and accountability are challenges. In the U.S., there's a drive to use primary care as the organizing hub for continuous and coordinated health services with seamless delivery. But when you think about it, as many primary care offices as there are, how could these hubs, these many hubs, do much to control something so big, right? So there's also accountability. There's provider accountability, where providers have to ethically provide health care in an efficient manner. They can't waste resources, and they can't withhold them. And patient accountability, which means patients have to step up to the plate and safeguard their own health as well, and also not overuse resources, use them wisely. So we're going to use primary care to try and organize this, with providers trying to be accountable and patients trying to be accountable, and we're going to just try and integrate this. And so with such well-laid plans, what could possibly go wrong? The last two traits I'm going to review of the U.S. healthcare system that makes it different from the other developed countries' healthcare systems is access is based on insurance and legal risk influences practice. So let's think about that. First, in order to even get access to care, a person has to have insurance in the U.S. normally, and the providers who are providing that care are pressured by legal risks. As described earlier, you pretty much need health care. You pretty much need health insurance to get health care. And because of the free market, providers take on legal risks when they deliver the health care. They are doing some sort of competition. And so when they offer a service and it has risks, they also have to have insurance against being sued. Even nurses do, as you can see on the slide. So let's compare us with the other developed countries that are our peers. Let's look at what is the difference between us and those developed countries that have universal access. Theoretically, no citizen is uninsured in those systems, and universal access is provided when a healthcare delivery system is managed by the government and provides a defined set of healthcare services to all citizens. So therefore, maybe not everybody can get everything, but everybody can get some things. Here are several models. Here's one from Canada. The core of care is delivered by private providers, but there's tighter consolidation of financing and it's coordinated by the government. You will see in later chapters that Canada limits the number of MRI machines, for example, that it purchases, all told. Yet there still are private providers who can compete to some degree. In Great Britain, there's the national health system, which is talked about a lot. It's tax supported by the people who live in Great Britain. The government manages the infrastructure for the delivery, and most medical institutions are operated by the government, and most providers are government employees. Very similar to our VA system, only that's the whole country. Socialized health insurance systems like Germany, Israel, and Japan have healthcare which is financed through government-mandated contributions by employers and employees, so it's done through employment. Healthcare is still delivered by private providers, but sickness funds collect and pay for services. Insurance and payment is closely integrated, and so delivery is characterized by independent private arrangements. In the face of all that, the government exercises overall control. So this is a little more complicated system than Great Britain's system. There's a little more involved, but ultimately the government still is mostly in control. So it makes you want to ask what the U.S. is doing wrong, because it's up here on the slide next to Canada, the United Kingdom, and Germany. When you look at some of these health indicators, like life expectancy for women, you feel kind of good. You're like, yeah, the United States is higher. But then, when you look at infant mortality, you feel kind of bad, because our northern neighbor, it's much lower. And you wonder why. Because when you look at who is paying for this, it's the consumers that are paying for that infant mortality rate. Here is the total health expenditure per capita, so that's per person, as a share of the GDP, United States and selected countries. Please notice that this is per capita, so per person. And please notice that the U.S. is way over on the right. We spend more per person in the U.S. on healthcare than any other country, and a good share of our people don't have a health plan. They don't have access to the care. Now let's end by looking at the systems framework. This is the framework we will use to try and understand this really loosely integrated sort of not healthcare system. The systems framework consists of a set of interrelated and interdependent components that are designed to achieve some common goals, but they're really not very organized. It explains the structure of healthcare services in the U.S. based on foundations and provides a logical arrangement of various components, and it does demonstrate a progression from inputs to outputs. But in order to better understand the textbook, consider figure 1.5 on page 25. It organizes the chapters into a systems framework so you can more easily remember how these components sort of fit together as we proceed. Here is the systems framework. It is separated into 5 components. First, there's the system's foundations, and these are cultural beliefs and values and historical developments. They're basically the foundation, what the U.S. healthcare system today has been built on. Then you have system resources. Literally, these are the human and non-human resources necessary to deliver healthcare. These include all those trained professionals out there, as well as all that fancy medical equipment. In addition, there are system processes. These are the continuum of care and special population care. So you have these different processes that people have to go through to obtain their care, regardless of whether they're on a health plan or not. At the end of the day, you have some system outcomes, so critical issues and concerns about a health service's accomplishments relative to its primary objective, which you may remember from the first lecture was to make sure to deliver health care to all its people. System outcomes are a place where change and reform can take place, because if the system realizes it's not producing outcomes from its processes and resources, then it can change them. And finally, we have the system outlook. This is planning for future trends. Trying to predict the future is a good idea because then you can prepare for it. We have now reached the conclusion of the last half of Chapter 1. As you can see, rather than one seamless system, there are actually several subsystems that provide healthcare delivery in the U.S., and there are several unique characteristics of the U.S. healthcare delivery system that makes it different from our other peer countries. In contrast to other countries, the U.S. does not have universal access, and it has unique implications for it. A systems framework approach is necessary to understand the U.S. healthcare system. Now we have reached the end of this lecture, and you should be able to name 3 characteristics of the U.S. healthcare delivery system, name at least one way in which U.S. healthcare delivery system is different from that of most developed countries, and finally, explain what a systems framework is.
Now that you have finished watching the second lecture over the last half of Chapter 1, you hopefully have a better idea of how the U.S. healthcare system is different from that of our peer countries, such as Canada, Britain, France, or Japan. We are totally unique in all the world, and you will see why in our next lecture over Chapter 2, where we go over the foundations of the U.S. healthcare system.